I'm here to talk a little bit about the treatment of epilepsy and some newer medications and modalities that we tend to use in our epileptic population for the management and hopeful cessation of seizures. So, what is epilepsy? Epilepsy is a chronic neurologic disorder characterized by recurrent unprovoked seizures that are attributable to abnormal neuronal activity. Epilepsy is distinct from an isolated seizure, which is one event or an event, a seizure event that's due to a specific metabolic derangement that can be fixed, such as a derangement due to change in the level of glucose in the blood, or a specific infection, maybe a trauma that's not going to turn into something that's chronic. So those are isolated seizures. Epilepsy is something where even without having a specific trigger, without having a specific medical derangement, you have the propensity to have seizures. About 1 to 2% of the U.S. population has epilepsy, according to a study in 2015, and really about close to 3.5 million people in the U.S., 3 million adults, and nearly 500,000 children have epilepsy. So historically, the treatment of epilepsy, the understanding of epilepsy, the classification of epilepsy was really based largely on spiritual and supernatural beliefs. It's described as the sacred disease, a falling sickness, falling illness. And the understanding of the etiology of epilepsy and where it actually originated in the body was not understood. And it took a while to really attribute it to the brain, period. Hippocrates had attributed to the brain earlier on, about 400 BC, but this was largely ignored for several centuries. By the mid-1800s, people began to believe this was attributable to brain activity, brain abnormality. And that's when you saw the first medications that were used, sedative bromide salt, to manage and stop seizures associated with epilepsy. Phenobarbital became available shortly thereafter in 1912 and became a very widely used treatment for the management of epilepsy. However, at that point, there was very little progress in the way of understanding epilepsy and finding additional medications that could stop epilepsy. It was a very painstaking process to come up with new medications, largely due to a lack of understanding of epilepsy and a lack of medical advances that would make the identification of new medicines easy. However, in the mid 20th century, the improved modeling of epilepsy and measures to understand the medication effectiveness and safety have led to a really large growth in the number of anti-seizure medications that we've seen, and we've seen this growth really remain steady over the last few decades. So this is just a brief chart that sort of goes over how significant our increase and improvement in the development and understanding of different medications for epilepsy has been. You can see sort of the bromide and the phenobarbital therapies that were quite prominent in the mid-1800s to the early 1910s. And then a sharp increase during the initial generation of epilepsy medications, anti-seizure medications. Then also, again, with the third generation, medications, another significant increase in the number of medications that are available. So typically the management of epilepsy really starts soon after diagnosis. And you want to spend a lot of time making a really good effort to classify the epilepsy based on the seizure type and the suspected etiology. You want to use a lot of the electrophysiologic neuroimaging data that you have that can help assist in the classification, namely the EEG, MRI sort of test. You can also add laboratory studies such as genetic testing to help you with the identifying the specific etiology and classifying the epilepsy. However, these aren't necessary all the time. If you've got a clear enough clinical history, you can make a pretty accurate diagnosis. The reason this is important is really because many of the medications that we have are sort of divided on the classification of epilepsy, and it tells you which ones to use and which conditions. Anti-epileptic drugs typically chosen based on the presumed etiology for the seizures. This is just a brief list, but a lot of times we look at the classification of the seizures and the epilepsy as a focal onset or generalized onset. And some of the medications that we have are good for focal and generalized onset seizures. And these are a few that you see right here. And then there's a group of medications that are good against the focal, but are used for non-generalized seizures, so seizures that are only focal that don't generalize. This is the group of medicines that is used for those. This group of medicines, if they're used in generalized seizures, or for patients with generalized seizures, can have some pretty detrimental effects and actually make seizures worse or more difficult to control. And this is just a specific medication that can be used for one specific type of epilepsy, absence epilepsy, which is classified or characterized by staring spells in children and a very specific electrographic background during those staring spells. So I'm going to go through a number of the medications that we sort of have on hand, that we have available for us. Talk about some of the older ones, some of the newer ones, and then some of the newest ones, before I move on to some additional therapies that we do have available. So conventionally, before 1993, we had a number of medications that had been developed and looked at for epilepsy. Many of these were developed in the 50s and 60s. Again, you see phenobarbital, which was early in the 1910s. So carbamazepine is a medication that really is good for partial or focal onset seizures. These can be used for seizures that do secondarily generalize. But if the patient has purely generalized seizures, it actually can cause an increase in those generalized seizures, particularly absence and myoclonic seizures. Adverse events associated with this medication can be depressed white blood count, sedation, ataxia, and nystagmus. Your benzodiazepines, I put clonazepam on here, also lorazepam and diazepam fit this category, can be used to treat almost all the different seizure types: infantile spasms, generalized seizures, myoclonic, absence seizures, focal seizures. They do have a side effect of sedation, cognitive impairment, and hyperactivity. Ethosuximide, this is a medicine that is primarily used to treat absence. Epilepsy can be used to treat myoclonic epilepsy, has adverse effects, nausea, abdominal pain. And typically you take these after eating to decrease that abdominal pain. So our oldest, phenobarbital, can be used with tonic-clonic seizures and some simple focal seizures in newborns and infants. It is a medicine that we use primarily in the neonatal population. It is an older medicine, which means it is fairly inexpensive and widely available. Does have some significant side effects, particularly allergic rash. It can make patients hyperactive with some other behavioral changes, and can, or at least has been reported to cause some cognitive dysfunction if taken for a long period of time. Phenytoin and fosphenytoin, this medicine can be used for tonic-clonic seizures and focal onset seizures. Adverse reactions can be hypersensitivity to the medication, gum hypertrophy, hirsutism, rash, fever, lymphadenopathy. And this medicine taken orally can be difficult for physicians to maintain a level, specifically in children. A lot of times we will give this medicine IV in the hospital, but upon discharge at home, patients usually do not take this medicine orally if they are a child these days with the newer medications that we have available. So primidone is another older medicine, but it metabolizes 2-phenobarbital, can be used to treat tonic-clonic seizures that are generalized or focal onset. And its adverse reactions are very similar, phenobarbital with rash, sedation, cognitive dysfunction. Valproate, this medicine can be used to treat generalized seizures, myoclonic, simple absence, myoclonic absence, myoclonus, and tonic-clonic seizures. The adverse events associated with this medicine are hepatotoxicity and, in rare cases, fatal liver necrosis. This medication does put a lot of stress on the liver, and typically before starting this medicine, especially if we're using it in a child who's younger, we'll get a lot of metabolic testing to ensure metabolic stability before stress that may occur when you start this medicine. A lot of the patients who have metabolic disorders are never given this medicine. If they are at risk for the hepatotoxicity, the liver necrosis, and even death. So some of the newer medications, really between about 1993 and 2005, exist here, and I'll kind of go through them. This is sort of the a class that has been developed that treats in a similar way as some of the older medicines, but the overall side effect profile tends to be a little bit better. These medicines we've had for now a few decades, so we kind of understand a little bit more the efficacy and side effect profile, and they tend to do a fairly good job at controlling seizures and provide us a little bit more of an opportunity to make patients seizure-free. So felbamate, this is a medicine that can be used against refractory partial and generalized seizures, primarily used in patients with Lennox-Gastaut syndrome, which is a syndrome seen typically in early childhood, with children having multiple difficult to control seizures. Seizures can be atypical absence seizures, atonic seizures or drop spells, and generalized tonic-clonic seizures. The medicine can be helpful for those seizures. However, it can also have significant adverse reactions such as liver damage, aplastic anemia, and nausea. Because of some of those side effects, it's not as widely used as others, but can have a place in the correct patient population. Lamotrigine, this medicine is used for absence seizures, atonic seizures, generalized tonic-clonic seizures, and specifically for the condition juvenile myoclonic epilepsy and Lennox-Gastaut syndrome. Adverse reactions associated with this medication include a rash, more specifically Stevens-Johnson's rash, which is a life-threatening rash, for which patients need to be taken immediately to the hospital for evaluation and management, and also dizziness, ataxia, double vision, and headache. Levetiracetam is a medicine that's really broad spectrum. It really fits most seizure types. Can be a good first-line medication, a lot of times used for juvenile myoclonic epilepsy. Probably one of the more ubiquitously used medications that we have for seizures. Does have significant adverse effects associated with behavioral changes with the onset of the medication. Many times this can be alleviated with some vitamin B6. So oxcarbazepine, this medication can be used for partial seizures that are focal or secondarily generalized. This medication can increase absence and myoclonic seizures. So if you have those, this is not the best medicine to take. Does have adverse effects associated with hyponatremia and drowsiness. Pagabine can be used for generalized or partial onset seizures. The adverse effects associated with this are somnolence and difficulty concentrating. Spiromet is used for partial onset and generalized epilepsies. Can be used for Lennox-Gastaut syndrome, can be a migraine prophylaxis, and a reasonable choice in patients who have seizures and migraine. Adverse effects, patients can have changes in their weight. Patients can report fatigue, altered mental status associated with high doses. Glaucoma can be rare, and kidney stones can also be rare in this medication. Zonisamide is a broad spectrum medication, can be used for primarily generalized and partial focal onset epilepsy. Adverse events include drowsiness, anorexia, decreased sweating, and hypothermia. And now we get to our newest medications, the ones that have been around since about 2005. These medicines, again, have overall can have a broader spectrum. I think we are understanding more and more the side effect profile associated with these. It does, again, give us more opportunity to make patients seizure-free. So vigabatrin, this is a medication that has been used primarily to treat infantile spasms, a condition in infants where there are clusters of brief myoclonic seizures that happen over and over. It can also be used to treat focal or partial onset seizures. The adverse reactions can be visual field defects and somnolence. Rufinamide, this medication can be used to treat head drop seizures and atonic seizures. Has adverse effects of headaches and dizziness. Lacosamide, this medication can be used to treat focal onset seizures and may cause dizziness and double vision. In some cases, it can cause hyponatremia. Clobazam, this medication is used to treat generalized seizures and seizures associated with Lennox-Gastaut syndrome. Adverse effects include sleepiness and constipation. Ezogabine, this is a medication that can be used for focal onset seizures, but it has the adverse effects of urinary retention and a bluing of the sclera. And eslicarbazepine, this is a medication that's very simple, similar to oxcarbazepine, can be used for focal onset seizures, and has an adverse reaction of hyponatremia. And breviracetam is a broad spectrum medicine very similar to levetiracetam. Can be used to treat generalized seizures or even focal onset seizures. Has adverse reaction of sleepiness and mood swings. So that's just sort of a brief, discussion, I guess, of a lot of the medicines that we have. There are really a large number of medicines when you look at it and you read them out in total for seizures and for epilepsy. But really the key is finding the correct medicine and the correct dose and limiting the side effects. And that's something that should always be discussed and maintained as a priority when managing a patient with epilepsy. I would say the decision to consider the discontinuation of a medication is really given to patients who are at least 2 years of, or who had at least 2 years of seizure freedom. The literature suggests that at 2 years of seizure freedom without a progressive neurologic disorder, patients who are weaned slowly off medication at that point have a higher success rate or higher chance of success in being seizure free off of medication than before the 2 year period. That being said, of course, every clinical situation is different, and the specific etiology, the patient's lifestyle, may affect the decision to discontinue. You can stop medicines at 2 years seizure free. You do not have to. And there are plenty of patients who do not want to stop what they're doing or want to continue to have the comfort that's afforded by the medications, or there are clinical conditions that appear to be progressive, for which many clinicians do not recommend stopping medication even after 2 years seizure freedom. So every situation is different, distinct, and requires its own decision-making protocol, but it is possible at 2 years seizure free to discuss the discontinuation of seizure medications. Patients who are, however, intractable should be referred to an epilepsy center for diagnostic assessment and evaluation of surgical and non-surgical strategies to treat the epilepsy. So intractability specifically is seizures that persist despite appropriate medical therapy with at least 2 anti-seizure medications. So not necessarily 2 at the same time, but 2 trials or trials of medication, at least 2 different trials of different medications for seizures. If you are not seizure free after that period, you should undergo referral to an epilepsy center and specific evaluation for surgical and then non-surgical strategies to help aid in seizure freedom. And the reason that we say that is sort of indicated here. So this is from a paper back in 2000, and there's been a lot of papers that have discussed this, but typically seizure freedom with the first drug, you're going to get, anywhere from 30 to 50% of patients with epilepsy who are going to be seizure free. After that, you're going to, when you try the second drug, there's going to be a significant amount less who are going to end up being seizure free. So in this chart, another 13%. So maybe about 60% who become seizure-free with one or two drugs, the first or the second drug. After that, you end up getting about a third of the patient population who, even with multiple drugs, do not become seizure-free. So that's at 36%. So after you get through two medications, if you're still having seizures, it is more likely that you're actually going to fall into the category of not being seizure-free on medicines than you are being seizure-free on medicine. So after two medications, we need to consider if there's something else other than medicines that actually might help with managing the epilepsy and the seizures. So our pre-surgical evaluation for patients with epilepsy really consists of non-invasive testing to identify if we can find one specific area of the brain where seizures start. Mostly that means coming to the hospital and getting a prolonged video EEG where we can capture seizures. And we capture seizures either by recording for days and days, or sometimes we'll try to stimulate the seizure through withholding of typical seizure medications, or even there are some medications that we can give that will help promote seizures. But the key is to capture them so we can identify if they clearly have a specific area of the brain where the seizure starts. We also do additional imaging, brain imaging, including MRI, PET scans, magnetoencephalography, SPECT scans, fMRI, to try to figure out, again, specific areas of abnormality where we think the seizure may be starting. And then there's also neuropsychological testing that can be done to identify areas of abnormality or cortical dysfunction that we think might house the seizure onset zone. After we get all of these different tests, and the key is really getting a lot of different tests from a lot of different modalities. So EEG is a different modality than an MRI, which is a different modality than a neuropsychological test. If all three of these different modalities point to one specific area of the brain as being abnormal and likely where the seizure is starting from, then I think the plan usually is to proceed forward and to discuss, surgical options, which could include surgical resection of a certain area or further testing, more invasive encephalographic testing to identify seizure onset areas. So the additional testing that may come about, the additional invasive testing, really is considered phase 2 testing. So it's intracranial monitoring. There are electrodes that are surgically placed in the area of presumed seizure onset. These can be depth electrodes, which are small electrodes that are placed into the brain, through the skull into the brain, or strip and grid electrodes, which are actually placed on top of the brain's surface. These allow for more accurate understanding of the epileptic network and identification of the precise seizure onset zone. Electrocardiography can happen as well. This is something that happens typically in the operating room, but this is another area at a time where electrodes can be placed directly on the brain's surface to identify abnormal areas and areas of seizure onset. With all that information, and if, again, everything seems to point to one specific area, patients do progress to phase 3, which is actual surgery for the epilepsy. This can include resecting a specific area, disconnecting a certain area that appears to be abnormal from the rest of the brain. It can include ablation and neuromodulatory procedures, and I'll talk about a little bit about that later. And then the phase 4 part of the evaluation is really the post-operative recovery and follow-up. So sometimes during the surgical or the pre-surgical evaluation, we identify either multiple areas or areas of the brain that cannot be resected, either because there's multiple different areas and you can't do multiple different surgeries, or you don't want to do multiple different surgeries, or it's an area that contains a pretty high level of function. So we call it elephant cortex. So it's a primary area where if we were to remove that area or affect that area, the patient might lose a very, very vital function, i.e. speech or memory. In that case, we do think about some additional modalities that we can do that aren't necessarily resective surgery, but are some additional modalities that can help stop seizure. One of them is the ketogenic diet, probably one of our oldest therapies. There are reports of fasting being used to treat epilepsy in the Bible. And this is used for seizures that can be refractory to anti-epileptic drugs. And what people have found is that the ketogenic diet causes a prompt increase in the plasma ketone bodies that the brain uses as an energy source. So the brain uses ketone instead of glucose as a primary energy source. Although specifically people don't understand what that does in the brain, it is thought to decrease the epileptogenesis and has been effective in many patients to reduce the seizure burden. There's also a modified Atkins diet, which is similar, but not as restrictive as a ketogenic diet that can help certain patients. So cannabinoids is another therapy tool that we can use. The cannabinoids, the main ones of interest include the THC and the CBD. So THC is the part of the cannabinoid that causes the psychoactive effects. The CBD doesn't typically cause that, but has been shown to potentially reduce seizure frequency. And recent studies have shown that it actually aids and can actually stop seizures in some patients who've been refractory to typical anti-seizure medications. Epidiolex, a plant-based CBD formulation, has been approved as of 2018 by the United States FDA for the treatment of seizures associated with DRAVET and Lennox-Gastaut syndrome. So there is a formal FDA-approved medication, CBD oil medication, that has been approved, that is in use by many epileptologists throughout the country to help manage seizures. Then there's also vagal nerve stimulation. This is a stimulator that's with a generator implanted in the chest that has coils that are electrodes tunneled into the left cervical vagus nerve. This stimulator goes on and off throughout the day, and actually can be, additional stimulation can be provided by swiping a magnet over the specific device in the chest. This has been approved for adjunctive treatment for refractory partial seizures, and sometimes can cause voice changes or hoarseness, but can actually make patients can actually significantly change patients' lives and be a substantial adjunct to seizure management. This is just a picture of the generator in the chest and the coils on the vagus nerve. So a couple other modes of therapy that can be available is responsive neurostimulation. So this is a surgically implanted device that's placed in the area of seizure onset. This device recognizes an abnormal seizure rhythm and actually delivers an electrical stimulus to abate this rhythm abnormality, kind of like a pacemaker. The good thing about this device is it can be implanted for months and years and actually record electrographic data for months and years. And so giving the clinicians plenty of information that hopefully will help fine-tune any management strategies to improve seizure burden. Deep brain stimulation is also another modality that's been used to decrease seizures. It consists of placing electrodes deep into the brain, into the thalamus. It's a deep area of the brain. It provides intermittent stimulation throughout the day, and overall that can reduce seizure frequency, and it can be approved for some adults. And thermal ablation. Thermal ablation is a way to actually affect a specific seizure onset without necessarily doing an open surgical resection. This is accomplished by placing a probe in the brain near the area of the seizure onset, and then using heat at the area of the probe to ablate or permanently damage that area so it doesn't start any more seizures. It can be less invasive than open surgical options. Okay, so in summary, epilepsy is a condition with multiple unprovoked seizures. Management is contingent upon the etiology of the seizures. The number of available medications have increased with improved tolerability and efficacy over the years. Persistent seizures, despite adequate medical therapy, requires additional evaluation for surgical options of seizure management. And then there are some additional non-surgical therapies that exist for seizure management, which may be appropriate in certain cases. Thank you for your attention.